Good morning, good afternoon, and good night. Thank you very much for attending this session by Dr. Luo. Expert on pulmonology, he is Chief Physician in Sichuan University's West China Hospital, as well as Deputy Director of the Respiratory and Critical Care Medicine Department. He was part of the first groups of medical aid teams sent to Hubei province in China. Today, he will share with us about the diagnosis and treatment COVID-19 through his frontline experience on combating the disease. We are currently connecting with you through two live channels, Zoom and YouTube. In case you are connected by Zoom, please mute your microphone during the session. If you have a technical problem or any other requests, please send a private message to the administrator. There will be no Q&A during this webinar, but we will be very happy to answer your questions after the session. Please join our WhatsApp groups for more interactions with other medical practitioners. And for more information, please send us an email to info@covid19alliance.com and subscribe to our YouTube channel.
Hello, everyone. Today, I want to talk about the challenge of diagnosis and treatment in clinical practice of fighting against COVID-19. I'm Fengming from West China Hospital, Sichuan University. I want to talk about the diagnosis and the treatment of COVID-19. And the challenge of the diagnosis, including history of the epidemiology and the physical examination and laboratory and special examination. But first, the non-pathology of the COVID-19. According to the manuscript papers reported, the inflammation and the mucus is very important in the lung in the patient of COVID-19. As to the history of epidemiology, and the incubation period is 1 to 14 days. Most of them is 3 to 7 days. It's very important to that clustering disease, because some of them are family members with the COVID-19 in a hospital. As to the clinical symptoms, most of them with fever, dry cough, fatigue, and a few patients were accompanied by nausea, congestion, running nose, and a sore throat. But running nose is not so common in clinic, and sometimes diarrhea. Maybe some patient with diarrhea just because of the medicine we used for the antivirus. In severe cases, dyspnea and hypoxia usually occur within 1 week or 10 days. And some children are relieved very quickly. Maybe the middle patients only showed low fever, slight fatigue, and a low pneumonia sign. As we know, we put on PPE in isolation ward. So it's just like me in the ward. It's difficult to use the regular stethoscope to listen to the sound of the breath. So we use the electronic stethoscope to connect it to the smartphone and recorded the sound of breath. As you know, there's some noise during the record. We have the distribution of the breath sounds in patients infected with the COVID-19. We can see here, there's a coarse breath sound with and course correctors, final correctors, and some patient had vector correctors in the base of the lung. Most of them distributed in the lower lobe of the lung. As to the virus detection is very important for the diagnosis of the COVID-19. We collected the samples from very gel swab, lots of very gel swab, and sometimes anal swab. And the sputum and other secretion of the lower respiration tract is sometimes has a higher positive rate in COVID-19 patient. We should test the samples within 4 hours after sample collection. If we want to test in a later time, for example, within 24 hours, you should preserve the samples in 4-degree centigrade, 4 degree. And if you want to preserve it in longer time, you should preserve the sample in lower temperature. We use the RT-PCR to test the virus. Sometimes we use the next generation sequencing for study. In Wuhan, we collected samples from nasal swabs and the pharyngeal swabs. We have 100 patients. We collect the sample with these two methods at the same time. As you can see here, if we use the pharyngeal swab, there's only 50% positive. But if you use the nasal swab, almost 90% positive for the patient. Sometimes the virus take time is very important. Most of the patient test the higher virus load load is within 1 week to 2 weeks. We can detect the virus in sputum and sometimes in the stool as well. And as to the confirmed case, the suspect case with the etiological or serological evidence. The etiologic is that we use the RT-PCR or NGS to prove that the nucleic acid of the virus. The serum specific IgM and IgG antibody positive. Sometimes we also use this to diagnose the patient. We also use a lot of CT scan for diagnosis. At the early stage of Wuhan, nucleic acid detection took a longer time. So if the patient is not diagnosed in time, then the patient cannot be separated and classified within time. After the inpatient improved, beds are occupied due to the unable to test of the virus. If you cannot test the virus, you cannot discharge the patient from the hospital. In a late period, the nucleic acid test false negative problem is very obvious. So we suggest that sometimes we use the CT scan for diagnosis. CT scan has high sensibility but lower specificity. So we suggest that clinical plus laboratory tests and combined with image to make a correct diagnosis for the COVID-19 patient. As to the role of chest imaging in the COVID-19, the Pressure Society published a recommendation, and I also took part into the discussion about the recommendation. We can see here that there's a different scenario for the recommendation. We can sometimes we use the CT and sometimes we use the chest X-ray. But for the diagnosis, I don't recommend that the X-ray. But if you want to monitor the disease, you can use the X-ray. Here is a 37 years old male, fever for 4 days. And the blood test is that a little bit decrease of the lymphocyte and then recovered. We can see here that the CT scan in February 24th. In the left lower lobe, there is a nodule, and you can also see that it progressed into the consolidation and within 2 days, and we can also see that the little small nodule in the right middle lobe of the lung, and after the treatment, all the lesions in the lung improved. We can see here that the patient had a high fever for almost more than 1 week, and we test the nucleic acid and throat, NO, and NOSTA. All the test is negative. And at the beginning, IgM is negative, and then almost 1 week, it's quickly positive, and then positive. And the IgG almost the negative. But after the follow-up, the IgG turned to positive. So this patient nucleic acid is negative, but the IgG, IgM indicate that this patient should be diagnosed with the COVID-19. After the treatment, the patient, the temperature returned to normal. The other patient, the female, 22 years old, fever for 2 days, and at the first nucleic acid positive, and even after the treatment, the CT improved, and still the nucleic acid positive. Without this patient has just later symptom. As to the, we should classification COVID-19 middle and moderate and severe and also critical condition. If according to the Chinese guideline, if the patient has the dyspnea, respiration rate greater than 30 times per minute, and pulse oxygen saturation less than 93% at rest, and oxygen index less than 300, and significant progress of CT lesion within 24 or 4 to 48 hours, this kind of patient can be diagnosed with the severe condition. If the patient has respiratory failure and need mechanical ventilation, or with shock or some other condition, indicate that this patient should be admitted to the ICU. This condition should be classified as the critical condition. Risk factors for progress to severe or critical condition include age. If the patient older than 65 years old, if the patient has overweight, for example, BMI greater than 25, if the patient has chronic lung disease such as COPD, IPF, And if the patient with the CTD, connective tissue disease, or associated interstitial lung disease, those kind of chronic lung disease maybe indicate that the patient will progress into severe or critical condition. If the patient with chronic heavy smoking or basic cardiovascular disease such as hypertension, some nervous system disease such as cerebral infarction, also chronic kidney disease, those patients maybe have high risk factors for progress to severe and critical condition. We should pay more attention to this kind of patients. Index of the severe critical type include that lymphocyte progressively decreased, or IL-6 or CRP increased within a short time. Lactic acid is progressed increased. Also, some CT lesion progress rapidly in a short time. For example, within 24 hours or to 48 hours. It's all indicate that this patient maybe should be pay more attention to. The second, I want to talk about the treatment. Let's include the treatment strategy, medical devices, and drugs and other treatment. And there's a word said that to cure sometime, to relieve often, to comfort always. To cure sometime means that there is still no specific effective antivirus at present. We should select antivirus drugs for patients according to their condition. To relieve often, that means we give support for the patients. For example, oxygen therapy, fluid supplement, non-invasive ventilation, and other treatment according to patient's situation. To comfort always means we should treat patients not only with medicine, but also with psychology. Strategy for treatment of COVID-19 in China. All patients with COVID-19 under the monitor of the healthcare staff. That means that all the patients should be admitted to a healthcare facility from middle to critical. The advantage of this strategy is that we can identify the rapid progress of the patient with COVID-19 early stage and give the patient enough treatment. And it's very important to give the sufficient respiratory support at an early stage to reduce tissue and organ hypoxia. If it's too late for the patient, maybe it's very difficult for a doctor to save the life of the patient. As to the respiratory support, we should keep respiratory rate less than 30 times per minute. Oxygen saturation should be greater than 95% and without obvious respiratory distress. We should monitor patients with high flow or non-invasive mechanical ventilation. If the improvement without improvement within 2 or 6 hours, we should intubation the patient with mechanical ventilation. And the prone position is very important. We should ask the patient to lie prone or lateral position. If the patient awake at least 4 hours per day, if the patient with sedation, we should put this position within maybe 12 hours every day. Sometimes we use ECMO for the patient if the oxygen is greater than 90%, but the oxygen index less than 80 percentage. Yeah, 80%. 80 for 3 or 4 hours. If the arterial pressure greater than 35, we should use the ECMO for the patient. We always use the VV ECMO for the patient. Sometimes we perform bronchoscopy for the patient, but we should protect the healthcare staff during the bronchoscopy with the COVID-19 patient. Here is a case that this patient was performed with bronchoscopy and with lavage. We can see here before the lavage, the right lower lobe is not so clear, and 1 day after the lavage, the patient the X-ray improved. This patient with ECMO, so we can perform lavage. If without the ECMO, maybe the oxygen decreased. So it's very important to keep the oxygen index. As to the prone or lateral position, I think it's very effective for prevent the progress of the patient and the disease. We have 17 patients included in our study, and also 35 for the control. After the treatment of the position intervention, you can see here the oxygen saturation index improved compared with the standard care. And ROX index also improved with the position intervention 7 days after the intervention. And the BOG score decreased significantly compared with the standard care. Though the time to clinic improvement did not show significant difference between two groups. I think it's just because we just have a very few sample size here. As to the antivirus medicine, there's no proven antivirus therapy. We use the interferon and ribavirin and Abidol and Cletra. We also use the chloroquine, and we should monitor the side effects, just like liver function injury, myocardial injury, and this kind of side effect. We also use the injection of the interferon. If we use the injection of the interferon, we can see here that we have a shorter time of stay in the hospital, also a shorter time of the virus turn to negative. Then we also use the anti-inflammatory medicine. If the patient with severe condition and with the dyspnea worst progressively, and also chest image progressed rapidly. We just use within maybe 5 days, and as according to the Chinese guideline, we used 1 to 2 milligram per kilogram per every day of the methylprednisolone. But it's very important to know when we use this kind of medicine and the dose of the medicine. According to my experience, I suggest that use when the patient suffered from dyspnea and other symptoms, worst within 2 or 3 days, and the lesion of the CT increased within 2 or 3 days, and no other contradictions for the steroid. As to the dosage, the guideline of Chinese said that it should be 1 to 2 milligram of methylprednisolone. Just used for 3 days. In my own experience, we used maybe 160 to 500 milligram of methylprednisolone per day. We have 30 very, very critical patients with the lower pulse oxygen saturation. Maybe sometimes it's only 38%. So this patient, we use the methylprednisolone. Maximum is that 500 milligram per day. We have 8 patients survived from this treatment together with the non-invasive ventilation, and only 5 patients died because of the very severe condition. 1 patient died from the shock and the DIC. Our treatment include convalescent plasma. We collect the plasma of the COVID-19 patient within maybe onset at least 3 weeks. We test the titers of the antibody, especially neutral antibody. All the patients COVID-19 patients should be tested for the nucleic acid positive. If the patient test with positive within 72 hours, we can use the convalescent plasma for the patient. We also use the antibody against IL-6. The indication for the antibody against IL-6 is that critical patient with extensive double lung lesion. We use maybe 400 milligram with the 100 milliliter saline. If the patient with infection also decreasing the leukocytes and severe liver function damage, if the patient with this kind, we cannot use the antibody against IL-6. As to the respiratory rehabilitation, we use the vibration expectoration drainage for the patient to get the sputum out of the lung. We use the breathing trainer and the rehabilitation exercises. We also perform the body rehabilitation training. It's very important for the patient to take exercises step by step, especially in the very critical patient. The discharge standard for the patient is that normal body temperature for at least 3 days, and the symptom and the lesion of a CT improved. Nucleic acid negative at least twice, and IgM decrease and IgG increase. After the discharge from the hospital, the patient should be quarantined at designed place after discharge from the hospital. Here is a patient. We can see here the patient, at first we used the mask for oxygen therapy, and the situation did not improve. So we used high flow, and still no improvement. We used the non-invasive ventilation for the patient. At the same time, we used the methylprednisolone, 40 milligram per day, and still the patient did not improve. So we give the intubation. After that, we increased the methylprednisolone to 120 milligram twice daily, and for 3 days, and then we decrease the dosage. And we also use the net prone position for the patient and use the antivirus, anti-infection medicine for the patient. At the same time, we use the anti-fibrosis medicine for the patient, the litifilimab for the patient. We can see here at the very beginning, the lesion of the CT is very obvious. And on the February 28th, and with 10 days later, the lung lesion improved, and the middle of the March, the lung improved a lot. We can see here it's very successful for the patient. In summary, we should make diagnosis combined with clinic and nucleic acid test, and also specific antibody together with the imaging. We should prevent disease progression under the monitor of the healthcare staff. We should give the patient sufficient respiratory support in the early stage. Thanks, everybody.
Thank you very much to Dr. Luo for sharing his knowledge and expertise. We have recorded this session so that you can have further study and share it among your fellow healthcare workers if you consider it useful. You can send an email to info@covid19alliance.com and ask for this recording. You can visit our website or follow us in LinkedIn to see the updates. In case you are connected by Zoom, you can find 2 group links in the public message of the room. We have established both English and Spanish-speaking WhatsApp groups for discussions. In case you are connected by YouTube, for further requests, you can also send us an email to info@covid19alliance.com and subscribe to our YouTube channel and keep updated for further sessions. Doctors, regardless of which region you come from or which language you speak, we are here to provide our unconditional support to you all. Thank you so much for attending.